Welcome, 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 everybody. Starting to see a whole bunch of faces in the audience. Thanks for everybody for joining us on this wonderful Monday morning. Now we've got daylight savings time figured out. I'm glad to see people figuring the schedule. I'm Dan Minter. I'm going to be facilitating today with my good friend Jack Penner. And we've got Priyanka and Sukriti are helping out with teaching points and scribing. I'll toss it over to Jack for a reflection on this gorgeous Monday morning.
Good morning, everyone. It is great to see you all. As I start to reflect briefly, we'll just put a call out for, as we do every day, two individuals to volunteer to facilitate alongside Dan and I, as we continue to work on finding gender parity within the world of clinical problem solving. We would love to have one of those individuals be somebody who really someone who doesn't identify as a man. And then if there's somebody who's also available to volunteer to present a case, please feel free to include your name in the chat as well. Most exciting, I guess there are two things that are worth celebrating today. Number one, for those of you who found out great news this morning about the match, a huge congratulations to all of you. I was reflecting that the number of people who I know are matching today, or who I know of that are matching today, has probably risen by like 5,000% compared to last year, just as a result of the VMR community. And so for those of you who got an exciting email today, we are so thrilled for you and wish you the best on Friday. And for those of you who may have gotten a less exciting email this morning, please know that we are thinking of you, and that the clinical problem solvers in the VMR community is always a resource for you, in addition to what I hope is a lot of support that you'll be receiving from your institution as well. And while things do work out, oftentimes over time, it can be a really upsetting day, and so we are definitely thinking of you. And in other news, this makes it the 1-year anniversary of Virtual Morning Report. As wild as that is to say, a year ago, we had a Google document that was just a straight up Google document that people were scrolling through and typing information, as I think Robbie was calling on people. I think there were 8 of us there who showed up for it as like an impromptu thing. And from there, it has continued to grow. And really the only reason that it still exists is because all of you who are here today do this so many days of the week. And so just a huge, huge thank you to all of you who have made VMR continue to persist and really made it into something that I know that myself, Dan, Moses, Charmine, Robbie, Reza, Anna, Smitha, all of the people, Lindsay, who have been involved with it from the beginning. It has become something that I think none of us imagined that it ever would have. And it is so exciting to see, so many people who continue to show up today. The number of new friends I have made, including Priyanka and Sukriti, as a result of this, has just been an incredible gift. And I think just to see kind of what this community has done for the world of clinical problem solving and creating such a safe environment for people to learn and show up every day. Just a huge thank you to you all. So thank you. I'll give a little heart emoji. And then while we wait for a couple other people to volunteer, we'll reflect briefly off of yesterday's case from Student VMR, which was an excellent case of a young woman who presented with months of abdominal pain and bloody diarrhea that was refractory to antibiotics, as well as neurologic findings, including paresthesias in the hands and fingers, as well as some weakness in the hands as well. And I think one of the interesting things that we got to reflect on yesterday was the overlap, or I guess how to think through when abdominal problems and neurologic problems present together. It's a rare combination of symptoms that have like a fairly narrow but fun diagnosis, to go through. And so we talked a little bit about how actually it's not uncommon for us to think about neurologic syndromes that develop after gastrointestinal problems. And we learned from I think a couple of people in the chat mentioned about how GI complaints can lead to the development of a peripheral nervous system process acutely, specifically like a post-infectious demyelinating neuropathy like we see in Guillain-Barré, but that it can also less commonly, an acute gastrointestinal infection can lead to a myelopathy via transverse myelitis. Now, differentiating between those two diseases can oftentimes be tricky, we usually classically think about a demyelinating neuropathy as a symmetric ascending process that starts in the fingers and then progresses up into the that starts in the toes, progresses up into the legs. Once it crosses the knees, we'll see it hit the hands, and we'll oftentimes see dropped reflexes as the thing that will be a clue to us that what we're dealing with is a demyelinating neuropathy and a peripheral nervous system process. Whereas a myelopathy may start with weakness in the legs. It's not always ascending the way that it is, and we'll oftentimes see hyperreflexia. But what's tricky is that early on in the course of a myelopathic process, or if the anterior horn cells are involved in the myelopathy itself, like in a true transverse process, you may actually see dropped reflexes in a myelopathy as well. That early loss of reflexes in a myelopathic process is akin to spinal shock. And then it takes a couple days for the hyperreflexia that we commonly associate it with to develop. And so the sort of murkiness in those two things is that you can have dropped reflexes in both a demyelinating neuropathy and in a myelopathy. But one thing that you don't always see in a demyelinating neuropathy that you may see in a myelopathy is bowel and bladder dysfunction, as well as a sensory level. And so those are three distinguishing features that can clue you into a myelopathic process. And so that was sort of our first DDX of abdominal pain to nervous system, was thinking about a GI infection leading to either Guillain-Barré or transverse myelitis. And then there was sort of two other things. One was how a chronic GI process can lead to not necessarily an inflammatory process, but a malabsorptive process, and thinking about nutrient deficiencies that can develop as a result of GI pathology. One of them being if the terminal ileum is involved, it can lead to B12 deficiency, which can present with a myeloneuropathy, usually subacute to chronic, like we might think of with DCML, with the B12 deficiency leading to demyelination of the dorsal columns, loss of vibration and proprioception, as well as a peripheral neuropathy with paresthesias. And then copper deficiency is something that you can also see that causes a myelopathy, a neuropathy, and then also usually hematologic abnormalities. And then the last piece, which is where we ended up going in this case, is that all of those things that we just mentioned usually cause symmetric processes, whether it's a peripheral neuropathy or a myelopathy. But you can have multifocal processes that develop, and in this case, that is what we saw. We saw a wrist drop and foot paresthesias, which raises the possibility of a mononeuropathic process or a mononeuritic process, like mononeuritis multiplex, which you can have in a vasculitis. So the vasculitis causing GI symptoms and causing nervous system symptoms. And then we sort of continue to take the mononeuritis hypothesis forward. The patient was found to be hypertensive, and on imaging findings, they had beating of the bilateral renal arteries with some hemorrhage and infarction around the kidneys. We were a little bit mystified, kind of went down the medium vessel vasculitis pathway, but ultimately, as it very often is in these sort of autoimmune conditions, it ended up being a patient who had lupus, which was, I think, a big curveball, but a reminder of the many presentations that lupus can have. Specifically, it was lupus complicated by a medium vessel vasculitis, likely driven by a hypocomplementic vasculitis in this patient. I thought it was a very humbling case, but also kind of a fun opportunity to think through those two symptoms that we don't oftentimes see together, the GI tract and the nervous system. And just to summarize again, 4 ways that the GI and the nervous system can be involved. 1, Guillain-Barré, 2, transverse myelitis, oftentimes which are both post-infectious. The third one being the nutritional deficiencies that you can see. And then 4th being a vasculitic process where a vasculitis affects both the nervous system and the GI tract. Unlike in the other 3 where you might see symmetric processes, in a vasculitis you oftentimes have a mononeuritis multiplex, so multifocal singular nerve involvement. All right, that's all I got. Do we have any case presenters or discussants yet?
Well, Jack, it looks like Gabrielle has volunteered to discuss a case, and Noah Rosenberg has Gabrielle has volunteered to present the case, and Noah is volunteering to discuss. We still need one more discussant, but in the interim, Gabrielle, do you want to introduce yourself to the group?
Hi all, my name is Gabriel. I'm from Lima, Peru. I'm very excited to be here today. I'm a fifth medical student in Peru. That is equivalent, I think, for MS2 in the United States. And so happy to be here. It's been a while since I presented a case to Jack, and I know we'll have fun with this case.
It's great to see you, Gabrielle. Noah, would you like to unmute yourself and introduce yourself?
Yeah, hey everyone, I'm Noah, fourth year going to IM in New York City. I've been off of clinical duties for a little bit, been teeing like some health policy stuff, and so it's nice to shake off the rust and get back into sort of thinking more clinically. Nice.
Welcome back. Welcome back to the semi-clinical space, clinical sim, we'll call it. It's great to see you here. And now comes the sad part, which is what I hope all of you are hearing, which is the noise of my heart starting to break a little bit as we wait for one more discussant.
Don't make Jack Cutter sad, folks.
No.
We need one more discussant. Hey, Jack, since I wasn't able to make VMR yesterday, what was the basis for the diagnosis of lupus?
Oh, an ANA that I think was like 1 to 1280, a positive double-stranded DNA, and a positive Smith. But interestingly, they also had a positive ANCA, but negative subserologies, and a positive RNP. So it was like a forwardly positive, panel. Interestingly, I thought that with the perirenal infarct that we saw, or sorry, the perirenal hemorrhage, that we might see that the patient had coagulation abnormalities and was going to have positive antiphospholipid antibodies, but they did not. But yeah, the ANA, double-stranded DNA, and anti-Smith were all sky high.
Interesting. Looks like your call out to the audience work, Jack. Mario has volunteered to discuss.
Mending my soul back together, Mario. Thank you.
Mario, do you want to introduce yourself?
Yes. Hi, everyone. My name is Mario. I'm also from Lima, Peru. I've discussed a couple of times, so excited to be here again.
I love the Peruvian presence here. I got to do a tropical medicine rotation at Cayetano in Lima when I was a med student. It just like blew my mind. Such amazing clinicians down there and really, really great didactics. Well, Jack, do you want to discuss with Noah and I'll discuss with Mario?
That sounds great.
Well done. That was very interesting. We are actually from Cayetano too.
Oh, really? That's amazing. Yeah, I did 3 weeks there and then a week in Iquitos and got to see so many amazing cases. Someday I hope to go back and do the Gorgas course.
Dan, do you want to take the first aliquot?
Sure, let's do it.
Cool.
So I could start the first aliquot with a shift complaint. So this is a previously healthy 20-year-old male patient presenting to the ER because he can't walk. And past medical history, he has asthma, he lives in Lima, Peru, and not medical allergies.
Do you want to give us any more information, or do you think it's good to start here at this point, Gabrielle?
The past medical history is a little bit long. So.
Okay. Maybe, can you tell us a little bit about the events leading up to him being unable to walk?
Yeah, so he has history of like 2 weeks of polyarthralgias.
Okay. And any trauma or anything?
No trauma.
Okay. Awesome. Well, we can start here, and I'm excited to see where this case develops. You know, I think ideally, Gabriel, just so we start thinking ahead, maybe like in 4 sort of discrete chunks of information with like the past medical history, exam and labs and whatever imaging you want. But we can, Mario and I can start discussing this at this point. Mario, I know this isn't necessarily expressly neurology VMR, but what sort of initial thoughts do you have coming through as you approach this, you know, potentially previously healthy young man who's now completely unable to walk?
Well, the first thing I would do is actually find out if it's difficulty walking because of pain, thinking of a mechanical issue, maybe associated with very severe arthralgias, or if it's a true neurological deficit in which the patient has no strength to be able to walk. So that would be the first branching point for me. And it seems to be that 2 weeks prior he was completely healthy. Well, that's what I'm assuming. That maybe that's not true, but it's the time course is more subacute than chronic or than acute. So what subacute causes can give you an ability to walk? I would be thinking some type of maybe spinal cord compression, maybe a disc prolapse, but that would be, I think, a lot more acute. Maybe something that it's been slowly growing in around the spinal cord. But I think before thinking about that, I would like to make sure I'm in which of the branching points I'm at.
Sorry, I was muted. We have a little bit of room to sort of speculate here. Like if it is neurologic, which again, you're totally right. Like maybe this arthritis points us in a different direction. If it is neurologic, you mentioned spinal cord. What other sort of possibilities might we add on to like neurologic localization of inability to walk?
Well, if I translating the inability to walk to maybe lower extremity weakness, if I make that assumption, you can have CNS, I mean brain and not spinal cord issues. For example, if you have I remember, I'm not sure what's the name of the variant, but if you have one anterior cerebral artery which occludes, you can have a bilateral leg weakness that could present like this. You could also have, if you have superior sagittal sinus thrombosis, you can also have that type of manifestation. That in terms of brain causes of lower leg weakness. Peripheral nervous system also could give you lower leg weakness, but it would have to be in this, if in this time course, it would have to be more of an acute polyneuropathy, thinking GBS, but I think we would have other manifestations other than weakness. Maybe, I mean, only other than only lower limb weakness. I know it starts especially in the lower limbs, but we should also have maybe some other type of weakness or other neurological manifestations.
Mario, that's amazing. And just what I'm hearing is you're totally right. Is it can be the sort of centers that control gait, or the neurologic components that control our gait, can be supratentorial, like you said. Like it could be like a midline parasagittal lesion, could be down towards like the thalamus, the brainstem, going into the spinal cord, and then like the nerve roots, the nerves, neuromuscular junction, and even the muscles. So I think you're totally right that having this systematic way of like going through both the central and peripheral nervous system for evaluating folks who have a neurologic cause of gait abnormality is totally appropriate. And I love how you walked us through that, no pun intended. So maybe if we on the flip side, since again we have limited information here and we're sort of like parsing tea leaves, what do we make of this polyarthralgias? And then we can kind of focus that by asking like, oh, this is a previously healthy young person who's now, in our schema of like, is this neurologic cause or is this like due to pain? What sort of polyarthralgia, could be so debilitating that it prevents a young, previously healthy person from being able to walk? That's kind of like how I'm starting to break this up, and we can just brainstorm together, Mario.
Well, maybe I should add something. I think I was just focusing on the spinal, on the corticospinal tract, but if this wasn't weakness, it could be disequilibrium. Maybe we could have a cerebellar or brainstem issue, or a vestibular issue causing gait instability, or maybe I think I would add those two into the discussion. In terms of like severe arthralgias, well, maybe if you have a septic arthritis, but I don't think you would. Well, I think that maybe the chief complaint will be a little bit different, right? It's like severe excruciating right now, right knee pain instead of maybe inability to walk. So maybe adding that, but in terms of maybe some type of severe erosive, maybe a spondyloarthropathy causing spondylitis or something like that, but I'm not sure what type of, especially in a young patient, right? Maybe if it was an older patient, maybe other autoimmune causes would come to mind, except for autoimmune, no, juvenile idiopathic, I think it's called arthritis. I think that's the name. So maybe adding that, I think would be a little, maybe more appropriate for the age of the patient.
Mario, I think that's fantastic. Again, filtering, like, we don't think a 20-year-old is going to have debilitating osteoarthritis, right? Like, if this is in an arthritis picture, then we're thinking like, oh, it's got to be probably more one of these like inflammatory arthritides. And I love that you mentioned septic joint, because that's got to be, you know, one of the cannot miss diagnoses in somebody, you know, presenting with debilitating, awful sort of joint pain. The other kind of things that we can consider if we think like, okay, what are, you know, sort of relatively acute to subacute sort of inflammatory arthritides, you know, what if this patient had like a chlamydial urethritis or like a Campylobacter diarrheal illness in the weeks preceding this? This could be a, you know, I've seen one case of a 24-year-old who came in with reactive arthritis to the point where he could no longer walk. So, you know, I think as we prime ourselves, you know, to think like both, you know, on the exam side, like, do we see signs of neurologic, you know, compromise, or on the articular side, like, do we see signs of an inflammatory arthritis? We can sort of start mapping it onto those things. The other thing that you'd want to make sure not to miss from an epidemiologic perspective is, you know, could this be a disseminated gonococcal infection, right? If we go down more of that arthritis sort of pathway, just thinking common things being common in 20-year-olds. So again, we're sort of stabbing at this point, Mario, just because we don't have more than, I didn't count it, but it looks like 10, 15 words or something on the page. And who knows, maybe Gabrielle is messing with us, so we can see where this case goes. But I think your approach of like, can we map on can't walk with joint pain, like saying, is it neurologic, or is this going to be a more musculoskeletal issue related to pain? I think like that's a very appropriate sort of map for us to follow as more information comes out about this case. And again, doing the thing that you so astutely did is filtering like, well, what could be happening with somebody who's young and otherwise previously healthy in both of those domains, whether it's, you know, an articular process or a inflammatory neurologic process, inflammatory compressive, you know, whatever you want, neurologic process, because again, he's 20, not 75, right? Why don't we leave it there? And Mario, just, you know, you knocked it out of the park, my friend. That was a fantastic discussion.
Yes. So with the history of the present illness, it all started 2 weeks ago. The patient referred nasal congestion and bilateral temporomandibular articular pain with no dysphagia.
Gabrielle, do you want to take Jack and Noah through the past medical history and social history and all that part?
Mm-hmm. Sure. 10 days before, the articular temporomandibular pain disappeared, and then the patient referred bilateral ankle pain. And also a pruritic erythematous maculopapular rash appeared. Mm-hmm. In the back and the superior extremities. So he received treatment with chlorpheniramine, and 9 days before, the pain located in the left hip and the left wrist. So doctors indicated ibuprofen and dexamethasone. And they did labs just for simplifying the CBC, the platelet count, the hemoglobin, the ESR, the CK, the electrolytes, the urine labs were normal. But they did an ultrasound and they found that a hip joint, the left hip joint, showed 6 millimeters of fluid, and they found no bone lesions, and they thought it was a toxic synovitis or synovitis. And the patient was discharged with aspirin, chlorpheniramine, and conditional tramadol. And now the articular pain didn't improve and also appeared a right hip pain. And all the metacarpophalangeal joints have pain too. And it was noted also erythema in those joints, in all the metacarpophalangeal nodes. The patient couldn't flexion the fingers and walk. In terms of sexual history, he reported 2 episodes of sexual intercourse with her girlfriend, no condom use. Do you want guys to stop there and discuss, or maybe do you want guys also the physical exam?
You can. I think, Gabrielle, I leave it up to you in terms of how you want to break it down. After this aliquot, we can do 2. We can do 2 more. And so if you feel like there's a lot of lab data to go through, then you can give us the exam here. But if there's not a ton of lab, then we could maybe do the exam in the next aliquot. It's up to you.
Yeah, I think I could leave it there, and then the next I could give you the physical exam and the 4 labs.
Perfect. That sounds great. All right, Noah, we had I think some really useful information to kind of better qualify what these symptoms were. I'd love to hear how you're now framing the case with some of this new information.
Yeah, this is some really interesting information here, and I'll say rheum is not one of my strong suits, so it's nice to practice and challenge myself with this. When I first hear of a young adult, my mind immediately goes to an infection. But as we're hearing more of these migratory patterns, sort of what I'd characterize like a migratory polyarthritis at this point, I sort of try to map on what Mario and Dan were focusing on, whether that's reactive to an infection, whether that's an autoimmune condition, because I'm centering more on the pain and the arthralgias and potential joint inflammation more than just weakness now, because that doesn't seem to be a prominent symptom as much. Things I'm trying to sort of center my mind around are the fact that he's been treated symptomatically and has not gotten better, which to me means one of a few things. A, he has a progressive autoimmune or inflammatory process that's not infectious, or he has an infectious process that's not being treated properly because it's not being treated. And so when I then think about this maculopapular rash, and for whoever is doing the board, thank you for perfectly highlighting that at the right time. I start to think about some of the vector-borne diseases, viral diseases, and uncommon bacterial infections that could cause a rash and arthralgia picture in sort of a subacute process. I have no clue about the sort of tick-borne diseases and vector-borne diseases in Peru itself, so I'd Google that. But things that immediately come to mind would be like dengue, chikungunya, Even like rickettsial diseases, I have no clue whether they're in Peru, but I mean, in the US, I would definitely think about a few of the rickettsial diseases, although they'd likely be a little bit more acute in process here. And then like Dan mentioned, the disseminated gonococcal infections. I'd also even throw syphilis in here. It can, I mean, to quote Osler, like if you know syphilis, you know all of medicine, and syphilis could really mimic a lot of different infectious processes here. So it certainly could cause a subacute in joint inflammation. I then sort of struggle to, I guess, map on the rest of what we've heard. I'm struggling to sort of map on the dysphagia and nasopharyngeal congestion and the TMJ pain, because the TMJ pain could certainly just be the first onset of joint pain and joint inflammation that he had. And the dysphagia and nasopharyngeal congestion could certainly be an initial nasopharyngeal viral illness or some small bacterial illness he had. And I mean, trying to think of other things that we've mentioned, like Neisseria gonorrhea first starts and is inoculated in the nasopharynx. So whether that can spread, I have no clue. Usually I think disseminated gonococcal infections are from sexual contact, and meningeal irritation comes from the nasopharynx, but I don't know the physiology enough to roll that out. So I guess to sum up a lot of that rambling, I'm really thinking a little bit more about the viral, the uncommon bacterial causes that could cause this maculopapular rash, and then would be asking a little bit more about his exposure history and if he had anyone else who had exposures around this time, like mosquito exposures, whether he was camping, whether he was outside or knew of any bites, and really try to tease that out a little bit more.
No, that was absolutely phenomenal. I have nothing to add. I think that was an excellent discussion, and I'm going to let it stand alone. Gabrielle, take us away into the next aliquot.
Yes. So the physical exam, the patient wasn't actually febrile. 37 Celsius of temperature, heart rate 92, blood pressure 100/70, respiratory rate 20, and oxygen saturation 96%. And the physical exam, the general appearance, he looks alerted, but he referred a lot of pain, especially in the hip joints. And in the skin, erythematous macules in the metacarpophalangeal joints, and urticaria-like lesions in the back and shoulders. Lymphatic exam, no cervical lymphadenopathy, and no inguinal lymphadenopathy. Pulmonary exam, expiratory wheezing, diffuse expiratory wheezing. Cardiovascular normal, abdomen, no hepatosplenomegaly, genitals, no lesions, and in the extremities, pain in active and passive movement in both hip joints, and pain inflection in the metacarpophalangeal joints in both hands. I actually have some photos of the rash that I was just recollating during the discussion, so I could share with you guys. So please, if you could allow me to share my screen for. Yeah, the most interesting about the rash is the urticaria-like lesions, term said so, in the back and in the shoulder, and erythema in the metacarpophalangeal joints in both hands. Yeah, that was the rash. And I forgot to mention that the patient 2 days before coming to the ER, he had an episode of asthma, of an asthmatic crisis. Any other thing that you would like maybe to know before going to the labs?
No, I think that's good. Mario, do you want to, it's a lot of meaty data to kind of go through here, and we're in a little bit different place than we were previously, but what are your initial thoughts kind of digesting this exam?
Okay, so I think we've localized our problem from the chief complaint to primarily to the musculoskeletal system, and I think there's a type of syndrome emerging here. So we have what appears to be a migratory polyarthralgia associated with what seems to me to be some type of I would really like to see the differential on the white cell count, because I'm having the sensation we have a eosinophilic problem here. So that's something I would be looking for. But I think with the wheezing and the urticarial rash, I think we have some type of allergic or pseudo-allergic issue going on here. And so trying to tie everything together, the lack of fever maybe makes me think less of an infection, especially an arboviral infection. I think dengue without fever, or with going on for longer than 2 weeks, that's pretty hard. Chikungunya could be, but without a lack of fever at the moment, that also would be maybe less on my differential. I think I would be looking for what diagnosis come in the overlap of migratory polyarthralgias and this type of urticarial rash. One thing I would say, I'm not sure if this term exists, but maybe some type of secondary asthma syndromes. I would consider maybe an EGPA manifesting with an arthritic component, and also with a pulmonary involvement here. But beyond that, I think I would like to see the labs, and I think we're gonna go into a autoimmune rheumatologic route. Those are my thoughts.
What amazing thoughts those are already. Thank you so much for going through that, Mario. Can I just clarify one thing, Gabriel? So is there actual inflammation in the MCPs, or it's just pain? Are the joints like actually swollen?
Yeah, it was actually inflammation in those joints. Okay,
and the exam, again, it's a little bit hard with the screen and stuff. The skin findings are urticarial. It's not macular.
Yeah, they're described as urticarial lesions, like in the back and in the shoulder. Okay. And in terms of the metacarpophalangeal joints, no urticarial-like lesions, they were like erythema. Okay. Maybe for the that could be explained for the inflammations of those joints.
In the timing of the rash?
Yeah, it started 10 days before.
Oh, interesting. Okay. Gotcha. Yeah, Mario, this is a weird case. You know, like I think if you initially parse it as like previously young, healthy person with, and I love how you said this, migratory oligoarthritis, you know, that gives you one set of differential diagnosis. And then if you add on like this persistent urticarial rash, that kind of takes us in a much different direction. So sometimes, you know, when I'm faced with things, and I think this is the fun part of clinical reasoning, is like, you know, I can talk about one certain thing, go all the way down through my schema, and I can talk about something else that doesn't seem to fit. You have to look for areas of overlap. So, you know, you mentioned allergic disease being kind of high on your differential diagnosis for urticarial lesions. You know, it's certainly like up there. And the thing with urticaria, you know, and urticaria is like the manifestation of like mast cell degranulation. It's a relatively non-specific skin finding that, you know, in general is pretty common. I imagine a lot of us in the, you know, on this call have had urticaria in the past. I think I had one like a week ago. But it can also, you know, be a harbinger for like an underlying disease. And the things that make you consider whether or not that this is a pathologic sort of manifestation of urticaria is if it's sort of relatively persistent, like doesn't go away quickly. If it resolves with, you know, hyperpigmentation or scarring, that could be an abnormal sign. Or if it's painful, any sort of like painful skin rash can also be something that you worry about. You know, it's again, we're taking Gabriel at his and the dermatologist's word that this is urticaria, but there's features that sound already somewhat atypical. The fact that the urticaria has been going on for what sounds to be like a week, 10 days at this point, which is a relatively long time. So now if we say, you know, if we say oligoarthritis and urticaria, I don't have a whole lot of things that immediately fit in that that overlap. One of the things that, you know, I'm not sure that the epidemiology necessarily supports is an urticarial vasculitis as like a pathologic form of urticaria that can be associated with like extra dermatologic symptoms. And the issue there is it's like a complex immune complex deposition, and some of the complement that's consumed will directly activate mast cells, and then you can get cutaneous urticaria. There's a number of other weird syndromes like Schnitzler syndrome that's IgM paraprotein associated that can be associated with like urticaria, potentially even like, you know, some neuropathy component, but we're not given other features of that. And again, filtering all of this through this patient's age. So I don't know, on the safe side, I might just back up and say rash plus arthritis and epidemiology and say like, you know, this patient should be tested for arboviruses, you know, given common things being common. You know, there's weird presentations of dengue, there's weird kind of like hypoinflammatory presentations of chikungunya. But, you know, I'm not super, I don't think anything's quite cinched at this point. I would wonder if the urticaria being something non-specific is, you know, true and unrelated, given that it sounds like he has a phenotype for asthma, perhaps, in allergic disease. And then go back to our original thought, Mario, of, you know, migratory oligoarthritis in a young person who had, you know, recent sexual, you know, unprotected sexual contact, and wonder if this is, again, you know, a reactive arthritis. So I'm a little bit flummoxed. After hearing that, Mario, anything else jump to your mind, or are you sort of putting things together in a different way, or any other thoughts?
I was trying to think I think the last information of this rash and wheezing, that's making me really think about what can cause that and what overlaps with migratory oligoarthritis. Mm-hmm. But for example, parasitic infections, I don't really associate them with an oligoarthritis, to be honest. One thing I would ask is, in systemic mastocytosis, I'm not sure if you can present with arthritis, but there's a sign, maybe Gabriel, the Darrier sign. I think if you like drag your finger over the skin, you can over one of the lesions, you can elongate the lesion. Was that evaluated, Gabriel? Maybe because
no, Mario, that wasn't evaluated.
Yeah,
because that's something I've learned that can be very specific for mastocytosis. So, but beyond that, I'm really a little bit, I think it's a lot of information to process, to be honest.
Yeah. Yeah, and I love how you're thinking like, oh, can I add in some secondary causes like the eosinophilic granulomatosis polyangiitis? Like, I think it's a great thought. The issue is, the age, right? Like systemic mastocytosis, EGPA, exceedingly rare in this age of a patient. So, I think that's where I'm struggling too is, what elements of this patient's context, are going to be sort of determinative in terms of the final diagnosis. So, and again, it's tough because both of these are relatively non-specific findings. I think like the thing that is most abnormal is, true arthritis of the joints that appears inflammatory, at least by imaging, because that seems to be the thing that's perhaps driving the majority of this patient's presentation.
So, something maybe I could add, something that came to mind when Gabriel mentioned the bilateral ankle pain is, but I think it wouldn't be also compatible with the age. It's Lofgren syndrome in terms of sarcoidosis.
Mm-hmm.
I know sarcoidosis can give you like an eosinophilic syndrome, but I think the age makes me think less about that. So I don't know. Let's see what comes after this.
Yeah, I love where your mind's at, Mario. Yeah, I think the labs and hopefully imaging will be illuminating. Back to you, Gabriel.
Okay, awesome discussion, guys. White blood cells, 10,900. Neutrophils, 75%. Lymphocytes, 20%. Monocytes, 5%. The platelets were elevated, 5,100. 500,000, sorry. And hemoglobin was 13. PCR was highly elevated, 50 C-reactive protein, 56.2 milligrams per deciliter. And they also did a Rheum panel, ANA negative, ANCA negative, PR3 negative, ANA negative, also. MPO negative, rheumatoid factor negative, anti-streptolysin O negative. Blood cultures were negative. They were thinking also in reactive arthritis, so they did the stool cultures, but they were negative. And the urethral swab culture was negative, and the gram of the urethral swab was also negative. In terms of the joint fluid analysis, I was searching for them, but I couldn't find it. But I remember it was compatible with aseptic arthritis. The gram was negative. The urine labs were normal, and they also did a Brucella agglutination test, which was negative. Yes, sorry for the lacking of information. I was trying to find it, but I couldn't.
No worries at all. And when you say that it was suggestive of septic arthritis, is that based off of just like a very high white blood cell count and a high neutrophil count?
Yeah, actually, it wasn't highly elevated, but it was most compatible with aseptic arthritis. It was mildly elevated.
Okay. And just to clarify, when you say aseptic arthritis, that means like it looked like the joint was infected, or it looked like it was not infected?
It looked like it was infected, but no gram positive, and the cultures were also negative. Okay,
awesome. Great. All right, Noah. I will say, just to put it out there, I am feeling, I think still not necessarily feeling like a definitive diagnosis is emerging here, but I think we do have some useful information and kind of some of the laboratory findings that we have here, and especially the things that we also have found that are negative so far. So yeah, I'm curious what your thoughts are.
Yeah, this is a lot of really interesting data. So I'll start at the top and work my way down. Mario and Dan really gave us a great picture of, with the data we had, thinking about maybe an autoimmune, but unlikely in this picture. Now thinking about like the white blood cell count, we have a neutrophil predominant with no elevated absolute eosinophil count, which I think sort of effectively rules out like a hypereosinophilic syndrome to me. And that was something I was thinking about as like a secondary differential to EGPA. But that rules out a lot of the eosinophilic processes, and the slight platelet elevation really is probably just due to inflammation. If it were significantly elevated, I think if it's above 800,000, it's pretty indicative of infections. But right now, it's fairly nonspecific, and we just know there's some likely inflammatory process going on in addition to the CRP. I'm not sure what. It's in milligrams. Okay, so it is significantly elevated. In terms of this autoimmune workup, which was pretty extensive for a first pass autoimmune workup, everything's negative, but I do want to mention that EGPA is negative ANCA in I think 40 to 60% of the cases, and so it doesn't effectively rule out when we have a good clinical picture for a syndrome, we can't anchor on just one test that doesn't have a perfect sensitivity. So that wouldn't rule something out for me. I'd still want to think about those autoimmune conditions that might be ANA negative, or even a reactive picture here that could be seronegative. Thinking about these infectious results in the blood culture and urethral swabs, when I think about culture negative infections and potential etiologies of sort of that, I often think of whether there's something intracellular that we won't get from a gram stain, or whether there's something really slow growing that we won't get from a normal culture, and whether this was at 3 to 5 days in the lab necessarily didn't report on it yet, and we had to hold on to it longer. Some of the sexually transmitted infections definitely could be culture negative. I think that's why we use like a nuclear amplification assay for the gonococcal and chlamydial infections, because they can often be culture negative, and then things like chlamydia and mycoplasma can be intracellular and gram negative as well. Brucella is another gram negative or intracellular organism that I can think of, but I'm blanking on other intracellular ones that could be without a gram stain. In terms of the joint fluid, I think that sort of points me a little bit more towards either a post-inflammatory. I mean, we don't have any positive cultures, so either there's something slow growing or missed out on our cultures that's infected the joints, but it's unlikely to infected all of these joints. And so, if we're thinking about like a septic arthritis, I would likely think more of this as an inflammatory arthritis due to a disseminated infection, or like a crystalline disease, like a calcium pyrophosphate, and gout are pretty uncommon in a very young adult. But I don't know the epidemiology perfectly of those. And so I guess all of this data together really points me potentially more towards either a disseminated infection that is slow growing or intracellular that we're not going to be able to get from a normal culture, and going to have some specialized infectious testing, or a reactive process, but we'd unlikely see a septic joint picture in a true reactive process, or maybe an autoimmune condition that's seronegative, or with like the EGPA could still definitely be a concern with the low sensitivity of the ANCA serologies. Yeah, I definitely want some further testing, infectious workup wise. In terms of autoimmune conditions, I'm not sure what else I would really work up. I think that'd be a secondary thought at this point.
I think Noah, I'm right there with you in terms of thinking through both the different infectious and the different potential autoimmune causes here. And I think, you know, whenever we're faced with sort of an overwhelming swath of negative data, question that I often then flip to ask myself is, okay, well, how or what does a negative test in this situation truly tell us? And in some situations, a negative test is very, very useful. And in other situations, a negative test is equivocal. And that depends on two things: the pretest probability that we have for the disease, and then the characteristics of the test itself, right? And so, for example, I was talking to Saman the other day, we were talking about fungal diagnostic tests. And in the presence of a patient where you have a high pretest probability for an invasive fungal infection, a negative beta D glucan test doesn't decrease your probability of an invasive fungal infection in a meaningful way that precludes you from doing further testing for it. And I think we can apply that analogy here to say, do we have a high pretest probability for a specific disease? And while I don't think we have an overwhelmingly high pretest probability for one single disease, we do have a decent pretest probability for a number of diseases that have been mentioned so far. Those include disseminated infections that can have clinical manifestations in the skin and the joints, but then also the lungs here. And then the other one is that we can also do we have an autoimmune or a rheumatologic condition that can have cutaneous, pulmonary, as well as musculoskeletal clinical manifestations. And then if we look at the tests that we have that weigh against that, we have a negative ANA, negative ANCA studies, and a negative rheumatoid factor. I think the diagnosis that potentially fits the best here, if we're thinking about autoimmune conditions, is the one that Dan had mentioned in the last aliquot of an urticarial vasculitis. But the most common non-cutaneous systemic manifestation of an urticarial vasculitis is joint involvement, and patients will oftentimes have migratory polyarthralgias and a migratory polyarthritis. I don't know what the joint fluid should show, or if they'll actually truly have an acute monoarticular arthritis that we see on top of the polyarthritis. But I bring up that illness script because we ask ourselves, well, what are the lab findings that we oftentimes see in an urticarial vasculitis? We'll see an elevated ESR and a CRP, and then many patients will have a positive ANA, but not all patients will have a positive ANA. And then the other lab finding that we don't have yet that would be interesting to know here is the complement levels, because urticarial vasculitis is classically a low complement vasculitis. Specifically, you can see a low C1q level, which can sort of be one of the things that can potentially really heavily favor that diagnosis. And so I guess the question that I'm asking in my mind is, does the negative ANA meaningfully decrease the probability of an urticarial vasculitis here? And I would say that my answer to that is no, but normal complements in conjunction with the negative ANA, I think, would significantly decrease it. What about a potentially disseminated infection, right? The most common cause in the most common cause of a septic or acute inflammatory arthritis in a young sexually active patient is disseminated gonococcal infection. And so we have to really make the effort to exclude that diagnosis here. And the test that we have so far to exclude that diagnosis is a negative urethral swab. And so then that begs the question of, does a negative urethral swab for gonorrhea decrease the probability of a disseminated gonococcal infection enough that we can say we don't even need to test the synovial fluid for gonorrhea? And I'm curious what your thoughts are on that question.
So for a few reasons, I'd say it's not sufficient. So one, when I think about sexually transmitted infections, the first thing I think about is location of transmission. We know that they have sexual intercourse without barrier contraception, but we actually haven't gone into the specifics of where the transmission should have occurred. So I would actually want to go into the sexual history a little bit more and talk to them about their sexual habits and figure out where we should actually be swabbing. The second aspect is the actual test characteristics of the swab, and I'm pretty sure cultures aren't too sensitive for gonorrhea. It's a gram-negative organism, but being gram-negative would not necessarily rule out that picture for me if this were to be urethral sort of in transmission from the urethra to a disseminated infection. So I would want the nucleic acid amplification, likely of multiple sources, maybe oral, maybe urethral, potentially a rectal swab as well.
That is excellent. No, I think you summarized that phenomenally. I have nothing to add, and I totally agree. However, the one piece of information that I'm struggling to reconcile now in thinking about the hypothesis of DGI is the asthma flare, right? Because I don't usually think about disseminated gonococcal infection, right? There's sort of two primary syndromes that we can see in disseminated gonococcal infection: the migratory polyarthritis, dermatitis, and synovitis. Or patients can present with an acute monoarticular inflammatory arthritis, or a classic septic joint. I don't usually think about pulmonary manifestations, but my DDX for not knowing something like that is because, one, it doesn't exist, or more commonly, two, I'm just not aware of it. And so I'm not sure how to exactly reconcile those two pieces of information. And then we get into a number of the other viral syndromes that have come up as well. But again, I'm struggling now to think about how those types of diseases can also infect the lungs and specifically cause not just any pulmonary syndrome, but an asthma exacerbation, which I think about as usually being either in a young patient and sort of what's the word I'm looking for? Like something like an asthma attack being potentially an IgE mediated or a mast cell mediated process in the presence of urticaria. And so I guess, I will say, I feel like I am a bit at a loss in terms of where to actually stake a flag on a specific diagnosis here, but I'm very curious to see what the complement levels are, to see if maybe an urticarial vasculitis is potentially one unifying syndrome here. But I'm also open to the fact that maybe this asthma exacerbation that I'm putting a lot of diagnostic weight on as being a defining feature of the clinical syndrome is actually true and unrelated, and we should just focus on the skin and the joint findings that we have here, in which case I think we would bring things like DGI up into the fold, as well as a reactive arthritis, potentially from an underlying viral disease. Because certainly you could imagine a viral syndrome triggering an asthma flare and then also leading to a reactive arthritis, but the time course and the sequence of events doesn't map on well for that. So I feel like I would be putting a square peg into a round hole of this case. And so that was a very, very long-winded way of me saying, I don't know, but we at least have some potential hypotheses to go forward with. And hopefully we at least built up some of our different illness scripts for some of these diseases that are under consideration here. But I'm very excited to see what Gabrielle's thoughts are.
Yeah, I loved what you said, Jaap, because actually, when this case was discussed, some of the pivot points that suggested like a diagnosis was the asthma flare and the urticaria-like lesions. And it was described, I didn't know that at that time, that Mycoplasma pneumoniae induces in some patients allergy by producing IgE. So when I say in this case, there's no clear diagnosis because it wasn't known if this was actually arthritis followed by Mycoplasma pneumoniae or reactive arthritis. But I would say that diagnosis was arthritis followed by Mycoplasma pneumoniae, and probably also reactive arthritis. What I learned from that case was that about the allergy in some patients for Mycoplasma pneumoniae, and this case was a little difficult because of the asthma, of the past medical history of asthma, because it can like shadow the pneumonia that Mycoplasma pneumoniae could be causing in this patient. And in terms of the other findings in Mycoplasma pneumoniae that are described, one of the most common is urticaria-like lesions. Other are erythema multiforme. There also was described a relation with vasculitis in Henoch-Schnoll in purpura, and Fudge syndrome, that is mucositis by Mycoplasma pneumoniae. And I don't know if there's any room in this room that could explain the reactive arthritis, because when I was doing some reading in this case, I found that in the 1999, there was established some criteria for that diagnosis, but the major criteria involves the arthritis that are asymmetric, mono or origo, and lower extremity involvement. And in this case, but there wasn't any leading point of enteritis and urethritis. But also in another literature, there was described other organisms that can lead to reactive arthritis, such as Strep pyogenes. But I don't know if Mycoplasma pneumoniae could lead to reactive arthritis. Some authors say yes, but that was the case. Mycoplasma pneumoniae IgM was positive.
What a crazy
awesome.
case, Gabriel.
Yeah, thank you so.
Go ahead,
Sorry,
Jack.
I was just saying, Gabriel, thank you so much for walking us through the reasoning. I think oftentimes, like whenever there's sort of some diagnostic uncertainty in cases like this, oftentimes it's sort of relying on the experience of very seasoned clinicians who are a part of making the diagnosis, and so it's very helpful to kind of get to download their thoughts for all of us here. So I just want to say thank you for articulating that period, but also articulating it in such a clear and easy to grasp way. Sorry, Dan, go ahead.
No, I was just gonna say it's such a fascinating case, and I was gonna ask, was there a pulmonary focus ultimately for the Mycoplasma pneumonia?
Yeah, probably.
Was it ever evident on like radiograph or anything?
They didn't do our radiography, but the patient was treated with azithromycin, and hopefully happily he got better.
Yeah, it's I've only seen one true case of it, and it's such a fascinating, differential for, like it's often like pneumonia with like extrapulmonary manifestations. A lot of community-acquired pneumonia can have extrapulmonary stuff, but Mycoplasma is certainly like one of the more characteristic ones. And now that I see the rash, it looks like this patient that I had that was like pseudo erythema multiforme, almost urticarial. But it's interesting too, because when you treat it, a lot of the manifestations are, sort of para-immune. So you get these extrapulmonary stuff from this weird immunologic reaction that you have. But yeah, fascinating case. Thank you so much for bringing it, Gabriel. Maybe I can toss it over to Mario. What sort of reflections do you have on like thinking through this case from the beginning to the end?
Well, I think it's crazy that we were in the first dialogue we were thinking about maybe a neurological disease, and we ended with Mycoplasma pneumonia induced reactive arthritis. So I think that's like the path a case can take you. It's amazing. I think I didn't have in my differential Mycoplasma as a cause of reactive arthritis. I usually associated that with genitourinary or GI associated bacterial infections, but so that's something I've learned. And I think just trying to keep in mind all the data from the past dialogues in such a complex case, I think that's great, great reps to get in, and it was an amazing discussion by Noah, Jack, and then I think it was an amazing discussion. Thank you, and thank you, Gabriel, for the case.
Thank you so much, Mario. You did a fantastic job, and I was just so impressed by your reasoning through this case.
Noah, any thoughts or final reflections from you before turning it over to Priyanka for the teaching points?
I second all of Mario's. I think like the only things I would add are something I was struggling with is as we go on in the cases, at what point do we manage when we're worried about a young adult? Like we were thinking a lot about pretty significant infections that actually have a decent mortality and morbidity, and autoimmune conditions that have a decent mortality and morbidity, and sort of not jumping the gun here. And I was wondering when we were going to, but we really, I don't know, just sort of help me clarify a little bit about when to take a step back and really think about the clinical context. I did not see this diagnosis coming, but it was really sort of really interesting to sort of put everything back and think about where we got to. Yeah, I've sort of at a loss for words beyond that.
I think your reflection is spot on, especially kind of grappling with I think thresholds of testing, but more importantly in this case, thresholds of empiric therapy is a topic that we could probably talk about for hours and hours and hours on end. And I think like you, I'm reminded of just how truly powerful epidemiology is, and that the kind of I guess the multiple ways and how some of these things that we oftentimes can hang our hat on, like sequence of events, gets a little bit messier when it comes to the real world. But I think that as with all of Gabrielle's cases, I oftentimes have more questions and more reading pathways to go down after they finish. And for that, I'm really excited. I'm really grateful. So thank you all so much for being here today. Let's turn it over to Priyanka for some teaching points to bring us home.
Thank you, Gabrielle. That was an amazing case. So I guess I'll start the teaching points with zooming out where we first started in this case, which was a relatively young person who presented with subacute inability to walk. And I wanted just everyone in the audience to refer to the neurosymptoms differential schema that's on the CV Solver's website, because it's a really good framework to approach neurologic symptoms. So in this case, it was important to consider the localizing the inability to walk along with the time course. And so that localizes to potentially the brain or the central nervous system, like the brain, the spinal cord, cerebellar etiologies, or the peripheral nervous system, which could have been localized to the muscles, neuromuscular junction. And in a young person who experienced inability to walk for about 2 weeks associated with polyarthralgia, that put us in the buckets of potentially this being an infection, an inflammatory etiology, and a neoplasm. And I thought that was a really good way to start off what appeared to be a very complex case moving forward, because it allowed us to sort of zone into 3 major things that we thought would be happening to this patient. As we got more data in the HPI, I think a lot of other things came to the forefront. This was a young person who had migratory polyarticular joint pain with a rash and an acute severe asthma exacerbation prior to presentation to the ED. I think, again, just sort of flushing out the differential a bit more, our infectious etiologies then expanded to include things like gonorrhea, chlamydia, viral infections like rubella, measles, dengue, Zika, chikungunya, fungal and parasitic as well. We also considered autoimmune diseases, including vasculitides such as EGPA in a patient like this, and urticarial vasculitis as well. One thing I think that maybe didn't come up as prominently, but in retrospect could have contributed, was mycoplasma in this case. And Gabrielle put an awesome teaching point in the chat that mycoplasma induces allergy by producing IgE in some patients. And so it could also fit the illness script of a young patient with migratory polyarthralgia, rashes, and asthma. The discussion that I thought really, for me as a learner and a trainee, was super elucidating was what happened towards the end of this case, which was collecting the clues and how to sit with and work through negative findings. So once we got a lot of the labs back, a lot of things came back negative, including the urethral swab, the gram stains, the blood cultures, all the vasculitic tests that we did. And I think that understanding how to process and work through negative tests is very important. And there was a really great discussion by Jack about that, Jack and Noah about that. So when thinking about culture negative infections, it's important to consider, could this be a chronic infection that we're not picking up on the tests that we have available to us? Could this be due to an intracellular organism? Or could this be due to an atypical infection like a fungal or a mycoplasmic infection? And so even though a lot of things came back negative in terms of the culture results, it was important to still keep some infections on our differential still. Then we moved on to the vasculitic results, in which predominantly the ANCO is negative, and also in the white cell count, there were no eosinophils And so it was then important to consider, okay, could this be ANCA negative EGPA? And Noah taught us that ANCA is positive in roughly 40% of patients with EGPA. So can we effectively rule out EGPA in this patient? And then the final thing to note is the negative ANA result. And if that could help us rule out or down arrow some of the other autoimmune conditions that were on our differential, including urticarial vasculitis. And we learned from Jack that one thing to look at is not just the ANA or inflammatory markers, but also complement levels, specifically C1q complement levels. I love that discussion on how to process and work through negative clues. And ultimately, the mycoplasma pneumonia IgM being positive helped narrow down the differential to being mycoplasma pneumonia with inflammatory arthritis. And I think retrospectively, we can map on a lot of the symptoms to this disease, but it truly was a journey to get there with a lot of learning points. Thank you so much.
Thank you, everybody. That was fantastic. Hope you enjoy the rest of your Monday. Wow, what a way to start the week. Take care.
See y'all later.